Okay, we can start. Good afternoon, everybody, and thank you very much to all have joined this session. I know that it's hard after lunch, but we will do our best for a session as integrative as much. But let's start. This is the session where we will address the topic about rural health as a way to assess and address access gap. Oh, thank you, Rudi. No, please come. Yeah. I'm Gian Matteo Apuzzo. I'm technical officer on primary health care at the European Center for Primary Health Care in Almaty.
And I'm Laetitia Bazzi-Veil, the deputy representative of UNICEF in Kazakhstan. And I will facilitate the session also with Tony.
Just to mention that this session has been in a way prepared by virtual roundtables that we had on the platform online, preparing the conference, and it was included in a wide topic of equity and well-being. And we are going to have an expert setting the scene, and then 5 speakers and some final reflection. It is important to mention that we will have time to also Q&A and discussion and also intervention from the audience. I thank you all the speakers. We are going to present them running the session, and thank you again to all of you for joining this session. Please.
Yeah, so just to say that this deep dive session will discuss the challenges of PHC in rural and remote areas with a specific focus on the change of the model of care, considering innovative organizational approaches and multi-platform service delivery models, as well as telemedicine and mobile teams. So I won't take too much time, and now we will be able to watch a video. Video?
Primary healthcare can be the staircase to a healthier and wealthier tomorrow. While our world is becoming increasingly digitized, primary healthcare remains rooted in the human-to-human connection. We all have a part to play. Join the PHC movement to shape our future and achieve universal health coverage. Transform, connect, thrive.
سال 1989 آمدم. آن سالها رسا سالهای وای بود. زایشی خانه در خانه بسیار بود. زنها عموما قید به نمی‌ماندند. سالهای پیش موریشی کودک زن هم بود. که اومدن و پیش دکتران به من یاری رسوندن و اونها همه شرایطشون مهیا است.
امروز برای تمام کارمندان سوهای تندرستی که در کپس ناحیه کار و فعالیت می‌برند مشکلی آنها را امروز آسان می‌گرداند. آنها برای آموزش گرفتن تکمیل اختصاص از کورس‌های بازآموزی و سمینارهای نو به نو آنها به شهر دوشنبه یعنی که سفر نمی‌کنند، در آنجا تجربه نمی‌آموزند.
مقدار مبلغ‌گذاری شبکه‌های موثر کاتس 10 مرتبه زیاد گردید. 80% آنها پورا با تجهیزات موثر طبی طبقی استانداردهای دولتی مجهز گردانده شدند. фақти модару кӯдак, миқдори бемориҳои сироятӣ ва ғайрисироятӣ дар маҷмӯъ дар ҷумҳурӣ коҳиш ёфтанд.
Thank you. Was an inspiring video to introduce the session, also to connect on what we have done yesterday in previous session. But now, for setting the scene, we have asked to John Wynn-Jones, that is our expert today. It's not easy to present John because he is a GP, more than 30 years of experience, one of the founders of the Rural Health Working Group in Wong, and we are very happy to have John to open and set in the scene. Thank you. Please, John. Come on.
Thank you both. Of all the elements of my career, the thing that I'm most proud of is that I was a full-time working rural GP in Wales for 34 years. As Matteo said, I was also the chair of the Wonka Working Group. Wonka is the World Organization of Family Doctors. And I established EUREPA, which is the European Rural Doctors. And we now like to think that we're more of a multidisciplinary organization. So my role today is to set the scene for my fellow presenters, outlining the rural context, and I think that's really important. The issues associated with providing access to care in rural and remote environments, and setting the scene for digital and remote mobile services. Look, if we're going to achieve universal health coverage in rural, around the world, it will be the rural areas that will actually provide us with the greatest challenge. So often, policymakers, academics around the world, and those are almost all based in urban areas, see rural healthcare through an urban lens rather than a rural lens. And according to the World Bank, 43% of the world's population live in rural areas. This means that over 3 billion people live in small towns, villages, hamlets, and other sparsely populated areas. So the proportion of the world's population living in those areas is actually gradually declining, many because of migration and many other factors. And as a result, we're left with a global rural population which is older, more vulnerable, and consequently has a higher burden of disease, non-communicatable and preventable diseases. So the rural population is particularly high, as you can imagine, in low and middle income countries. Again, this is from the from the International Labour Organization. In Africa, over 60% of the population live in rural areas. However, to quote the International Labour Organization, it's not just a low and middle income problem. It says that the rural-urban divide is omnipresent from the richest countries down to the poorest. So rural populations face challenges such as poverty, lack of access to education and healthcare, and limited infrastructure. Addressing these challenges will ensure that people can benefit who live in rural areas from economic development. Again, going back to the ILO, 56% of people living in rural areas worldwide do not have access to essential health services. This means that 1.8 billion people living in rural areas do not have the access to basic health services that they need to manage their illnesses and stay healthy. The lack of access to healthcare is due to a number of reasons. One of the main reasons is the shortage of health workers. Only 23% of the global health workforce is deployed in rural areas. Rural healthcare systems are often underfunded, making it difficult to build and maintain facilities and attract and retain healthcare workers. Funding formulas do not take into consideration rural issues such as population sparsity, the disease burden, and distance. As I said before, rural areas have poor infrastructure, such as roads and transport, and it makes it difficult to access care. People living in rural areas are often poorer than those living in urban areas. And according to WHO, Globally, extreme poverty continues to be overwhelmingly rural, accounting for 4 in 5 of people living in extreme poverty. Now, the lack of access to healthcare in rural areas impacts on the health of rural population, with higher rates of preventable and non-communicable diseases such as malaria, tuberculosis, HIV, cardiovascular disease, etc. And they also have lower life expectancy rates. The imbalance caused by the lack of health workers is due to several factors, leading to poor levels of recruitment and retention. These factors include poor working conditions, cultural issues, personal security and safety, and levels of remuneration, and the lack of specific rural training. Rural health workers provide a wider range of complex skills and services, and they're often not prepared for that in their training. The case is clear that the workforce will need to be trained and need to be supported through digital connectivity. The rural workforce is also aging with no one to replace them. To conclude, we need to provide our communities with safe, effective, efficient and comprehensive care. In the ideal world, it would be great to have personal contact with a healthcare professional, but sadly that's a long way away. So today we're exploring the use of mobile and digital alternatives which can provide access and begin to address some of those health inequalities that I've outlined. So these presentations will demonstrate how these innovations can have an exciting and positive impact. A word of warning for you, however, is that I see digital options as only tools rather than solutions. They must not replace that human contact that we heard about before lunch. So, to finish, you're going to hear the term today, multi-delivery platforms. And it'll come up on a number of occasions. And it denotes the importance of using a range of tools in order to progress towards rural universal health coverage. So, I'm sure that you will agree with me, and I hope that you'll get a better understanding after the presentations, that our rural populations deserve better and they deserve more. Thank you very much.
Thank you very much, John, for these inspiring words. We have tried to shape a panel touching all these issues and components that John has addressed in this introduction in different parts of the world. So I'm happy to start with the panelists. And the first presentation is from Andreas Lundqvist. We asked Andrea to be the first panelist because he's going to present the experience in Region Västerbotten in Sweden. We are so happy because Sweden is also one of the 2 demonstration platforms that has primary care center in Almaty. We have one is in Kazakhstan, the second is in Sweden, and we have asked Andreas to be the first because it's really a comprehensive approach to rural health. So very happy to have you with us, and the floor is yours. Thank you, Andreas.
Thank you so much. Thank you for the invitation today. Very honored to be here. I'm going to talk to you about how we have addressed the rural access gap in Västerbotten through the cottage hospital model and also our community health rooms. And I will also mention briefly to you the work that we do at the Center for Rural Medicine and why it's important to work with research and innovation in rural areas. We can have the next slide, please. And I want to start off by showing you the area I will be talking about so you get a sense of the geography and the demography. The county of Västerbotten is located in the far north of Sweden, and it's the 2nd largest county by surface area. However, we're only 276,000 people, and 80% of them live by the coast. So the inland and mountain area of Västerbotten is very sparsely populated. In some municipalities, there are less than 0.5 persons per square kilometers, meaning that in some EU statistics, they don't exist at all. What's also specific for our area is that the population is old, as we've heard from John in the introduction here, many being over 65 and also many being over 80 years of age. So we're sparsely populated, our population is old, and we have long distances to almost everything. These are all factors that puts a lot of pressure on the healthcare and care system, and we have tried to address this over the years with research and innovation projects. We can have the next slide, please. And one way of addressing the rural access gap is to strengthen and extend primary care, which we have done through the cottage hospital model. The cottage hospitals are spread out in South Lapland, which are the inland and mountain area of Västerbotten, marked as bright red in the map to the left in the map. And they do a lot more compared to what you would normally see in primary care. And they also have a close collaboration with the nearest hospital, which is in Lycksele, marked as green in the center of the map. For example, they have a ward with 8 to 16 beds. They have a 24/7 emergency room. They have access to very advanced tools in the form of digital X-ray, ultrasound, telemedicine equipment, in-house lab, and much more. The cottage hospital is also a very good example of integrated care, as the wards are a cooperation between the region and the municipalities. The roles for healthcare staff, healthcare workers, are also extended compared to what you would normally see in normal primary care. Another concept, looking to the right in this slide, that we have in place is the community health rooms that we have used to address rural access to healthcare. And they are located in very remote villages in the area. These rooms give easy access to self-management equipment and video consultations, and some of the rooms are also staffed with nursing assistants from the municipality's home care, at least for some hours every week. We can have the next slide, please. I'm finishing off with some words about my unit, where I work. We work with research, development, and innovation and education for and in sparsely populated areas. And we do so in the areas of good quality local healthcare, Sami health, which is health for our indigenous people, recruitment and retention. And historically, we have worked a lot with how we can move healthcare as close as possible to our rural population, many times using distance spanning solutions and point of care diagnostics. But we've also worked with how we can evaluate and strengthen the healthcare that is conducted physically in our part of the country, once again through the cottage hospital model. And for us, it's a matter of credibility to actually be based in a sparsely populated area. As John mentioned, there is often an outside perspective when rural or sparsely populated areas are to be involved in research and development, and we have a strong belief that this is not how it should be done. Innovations and solutions that have been developed in sparsely populated areas can also many times be scaled up and used in a more urban setting, but the other way around rarely works. So, thank you.
Thank you very much, Andreas. Very interesting presentation of this approach, as I said. And now we pass to Mr. Alen Šeranić. I'm delighted to have Alen with us. First of all, because I'm focal point for Bosnia and Herzegovina in Almaty, but also because I had the chance to visit Banja Luka last May and see how they organize primary health center in rural and suburban areas. There is a very good model of family medicine, and each municipality has a health center, so the coverage is really good. Can you, Alen, present how is organized the health center? And thank you for being with us today. The floor is yours.
Thank you very much for this introduction. I would like, first of all, to say thank you for the invitation for this conference. Of course, to our Kazakhstan's host, to say thank you and all the greetings. First of all, I will try just to explain some points which I think it's very important from the side where I'm coming from. And I'm Minister of Health and Social Welfare, so I'm the guy who doing the decision making. And sometimes it's very difficult to do it, but I'm lucky because I have a health and social welfare at my ministry, which is very important for the primary health care. The accessibility, the quality and efficiency. Three main things that we are streaming in health systems, but the problem with those three things that sometimes they cannot go together. So if you want the accessibility, you cannot get the efficiency, or if you have efficiency, then it's difficult to have accessibility. But in this moment we are lucky with the digitalization, because that's a tool which are making these varieties very narrow. So with the digitalization, you can get the accessibility with low costs, for example, and try to provide the healthcare. So it's just a tool, as John said. Don't see it as a solution. That's very important, because if we start to see the digitalization as a solution, then we will be in much bigger problem than we are possible now. But the system is organized with the primary healthcare centers in each municipality, and that centers consist by family team medicines. Family team medicine is team with a specialist of family medicine and 2 nurses, one which is responsible for the organization inside of the team, and second one which is responsible for the community nursing. Family medicine teams are supported with the radiology, with a pediatrician, with gynecologists, with laboratories, but the second very important things are multidisciplinary centers in primary healthcare units. We have center for mental health, we have center for physical rehabilitation, and from last year we have centers for health promotion and disease prevention. Again, this is support to the family medicine. What we actually realize that the family medicine doctors and as nurses as well need support to fulfill the obligations for the community health. And that was one thing that we tried to establish, because in multidisciplinary centers, for example, those ones with mental health care, we have social workers, we have psychologists, we have speech therapists, we have the defectologists. So we are going to provide not only the healthcare as well as the social service welfare inside. For example, for any kind of screening programs, we also realize that family medicine doctors who are the closest doctors to the patient needs support for logistical and organizational side. And that's the Center for Health Promotion and Disease Prevention. So we just support all those teams inside of primary healthcare. So the multidisciplinary is actually the main thing that is going to give, again, the support to the community, which we also include in the financing of the primary health care. So it's not only financed by the health insurance fund who is buying the health service from the primary health care, it's also financed for the specific programs by the law for the communities who are also obliged to finance the sum of health services. The second thing which I would just like to mention is the health workforce. Again, support. So what we realized from the ministry, from that kind of support, that we need to develop not only the clinical, the non-clinical skills. For example, we have special programs for the communication for nurses, which is very important because they need to have such a kind of soft skills, let's say, and also we now develop the program for subspecialization for primary healthcare doctors. What I'm talking about. So every family medicine doctor is specialist of family medicine. But we also realize that we have burden in hospitals concerning some specific issues, for example, diabetology. So we offer the subspecialization for family medicine doctors, not in endocrinology, which is hospital side, then in diabetology, for example, or in angiology, or in public health, or in nutrition. So we just give them some field to be motivated to continue to work at the primary healthcare level and to feel a little bit as a part of clinical side. What we do with that? So we didn't push from the health insurance fund all the money for these specialist services in the hospital. Then we took a little bit from the hospitals and put it to the primary healthcare centers. What is, again, the issue which is important for the motivation. And third thing, just to talk a little bit about digitalization, 2 years ago we implemented the integration health information system, which is responsible for whole health system in the Republic of Srpska, where I'm coming from. And on that base, we implemented the telemedicine and mobile medicine, which we first defined by the law. And that's my suggestion. Please, if you are going in that field, you need first to develop the legal framework, because if something goes wrong, then everybody are in problems. So please, just to have that on your mind. Don't wait or don't accept from IT specialists the solutions that they are giving to you before you don't have, if you don't have the legal framework. So we, on that base, implemented telemedicine, for example, for internal care unit, but that's a hospital side, but that experience we are using actually for primary healthcare. Thank you.
Thank you very much, Mr. Šeranić. So now we pass to another region, continent, and we will hear about primary healthcare initiatives in rural and remote areas in Chile. And let me introduce María Soledad Martínez Gutiérrez, Head of Primary Care Division of the Ministry of Health in Chile. So Chile is a country with very remote areas with a problem of connection and transportation. It's also a country that has experienced diverse and very different phases of migration and also has an indigenous population. So, dear María Soledad, can you tell us how you are dealing with all these specificities when planning and implementing primary health care? Over to you.
Thank you for the invitation. If I can have my presentation. So I wanted to tell you a little bit about rural health in Chile. We have, as we were saying, a declining population in the last few years, but now it's a rural population. But now we have seen, after COVID, that there's been some some city-country migration, actually, because people now have moved to the rural areas if they have access to internet, because they can actually work there. So it's been very interesting, this counter movement from the city to the country. The next one, please. So this is Chile. Chile is in South America. It's a very long country. We have desert, we have jungle, we have Antarctica. So lots of rural areas. And it's important to, I was talking to you about the decrease in rural population, but increase in recent years. We also have been having a lot of international migration from Haiti, from other countries in Latin America, and we were not really prepared for that. It was in a very short time, span of time, and we have them settling in cities, but also in rural communities. We've been detecting, identifying fewer transportation services in rural areas, which are increasing the out-of-pocket health spending, specifically because people have to take an Uber to actually go to a primary health care center, and that's really expensive. And then we've been having some situations like stress settings, which we were not accustomed to that as well, and so we have to face those challenges in a very short time span. We have, as I was saying, migrants and refugees, but we also have been working with indigenous communities. We have seen an increase in rural violence, and that's something that we're very worried about. Not only associated with communities and indigenous communities, as it was before 10 years ago, 20 years ago. Now we also have some criminal gangs in the rural setting. So it's really complicated to actually go and do the medical rounds, for example, very unsafe for healthcare workers. And also climate change, which is which I don't know, like 5 years ago we just said climate change. Now we're living it every day. Every 3 months we have a flooding, or we have fire, big fires, and now we're going to have a heat wave. So we need to work on that, and in rural settings it's even more challenging to work on that. And so we have emergency and disaster situations all the time. And what John was saying, the aging process in the rural population is also a phenomenon that we have been seeing. Next, please. We just want to show you a little bit of the interventions we're doing. In rural areas, we have health posts, like little health posts with one technician, health technician, but we don't have, in these rural populations or communities, we don't have the whole multidisciplinary care team, which we have in the urban settings. But these multidisciplinary teams go and do rounds in these little health posts. And they also go to visit, like here, they go to visit people. And this has been done for a long time. There's some reinforcement of healthcare workers in a program that's called the Rural Health Equity Program, but it's underfunded. We need more funding for that. We also have projects for improvement of the local management capacity, and we've been doing some very small projects, but for security for healthcare workers, as I was saying, for the medical rounds, and also for connectivity, and for emergencies and disasters. And we also have one interesting initiative, which is the Rural Digital Hospital, which is not for the patient, but for the technician that is working in the health post. So for that technician, they have access to a doctor from 8 a.m. to 8 p.m. So they can do that consultation with a doctor if they need it. And so that's a very good, but it's not in every health post. We have 1,200 health posts. Not all of them have this possibility. And why not? Because a lot of health posts don't have internet connection. So what we've been doing is trying to increase the coverage of internet connection, specifically through satellite internet, because when we have other kinds of internet, there's problems with the cables. They steal the cables, for example. When you have an antenna, some people, like, we don't know really who, probably criminals, but they actually turn down the antenna. So with internet satellite, it's much easier to actually have this access, and that's what we're trying to do for extremely isolated communities. The next, this is the last one. So some barriers and success factors. As you can see, we have the country, like the very typical country, but we also have these more desertic areas. And the barriers are the resource allocation model that we have in Chile is a per capita payment. And so rural areas have really small number of population. So the per capita is really small. And we do have some adjusters, some indexes that kind of take into account the rural situation, but they are not the ones that we want, and they do not capture the whole rural situation. And there's also technical diversity in local health management workforce. Some people do very good management, and they are very innovative, and some other just don't have the capacity to do that. And there's territorial stress factors, as I was telling you. And success factors, we have an integral model of family and community healthcare implemented in Chile, and that really takes into account differences in the territories, and rurality, of course, is one of those differences, and it's a good model for different kind of scenarios. We have the rural health equity program that I was telling you about. We have resilient communities. We saw this in COVID and also in the recent disasters. And we have a municipalized primary healthcare system. And so that's also very interesting because the municipality that has actually rural areas can make some tailored solutions for them, which will not be the case if everything was centralized. So that's it. I just want to tell you that it resonated with me, the message that we've been hearing yesterday in the workshop and today in the conference. One size does not fit all. And so for rural areas, this is key. We need to do tailored interventions, and we're trying to do that in Chile. Thank you.
Thank you very much, María, Soledad. So now, remaining in the same part of the globe, I'm glad to introduce Dunstan Bryan, who is the Permanent Secretary of the Ministry of Health in Jamaica. So we know that the Ministry of Health and Wellbeing of Jamaica has developed a digital vaccine information management platform for COVID-19 vaccine deployment nationwide. And this digital solution helps to manage and record scheduling, patient screening, and reporting. So Dunstan, please, can you tell us what has been the two most critical challenges in transitioning from paper-based to digital health solutions? And also, what do you consider the two most critical lessons learned in moving your healthcare workforce from a paper-based to a digital system? Over to you.
Thank you very much, and thank you to the organizers of this conference for the invitation. Now, Jamaica is a small island developing state, and we have a population of around 2.8 million people, and we are separated into 4 health districts with approximately 225 health centers with 27 hospitals. Now, only about 15% of our health systems are digitized. So we have a massive problem of just manual systems. And when COVID hit, COVID represented a mammoth task. And that was a significant move that we had to make because right now, we have a birth rate of about 45,000 live births per year. And we vaccinate that number of children within the space of a year. But within COVID, we had to vaccinate approximately 1.7 million people within 6 months. And that was a massive task that we had to undergo to move from a manual system to an electronic system in order to go through that entire system of recording and documenting the vaccination program throughout the country. Now, like my colleagues around it on the panel, we do also have an issue with internet penetration. And so we have limited penetration of internet in our rural settings. And so we had to formulate a lot of strategies on how we were going to roll out our vaccination program in a digital way because it could not be done in a manual way, and how we were going to do that within the short period of time that we had. So we immediately went into a program of planning, and that program of planning led us into looking at what the strategy is. And we had a 10-week implementation timeline, and within 10 weeks we were able to stand up an electronic platform for immunization in COVID. Never has it been done in Jamaica in that way. Significant innovations had to be done in terms of just transforming people's mindset because our nurses and our doctors were wedded to our manual system. That immunization register in the book, in the big book, was the Bible. And if you were not in that book, you were not immunized. And so to get persons to shift their mindset from the big manual book to a tablet was a massive change that we had to undergo. The other aspect of the work that we had to get into was the fact that we had to change mindsets on who could vaccinate. Our public health nurses, that was their area of specialization. And so they insisted that the doctors couldn't vaccinate, neither could the pharmacists vaccinate, no one else could vaccinate but us. And so we had to change that mindset, and that was a difficult challenge for us. And the whole business of hiring persons. Now, being a small island developing state, close to the metropoles, close to the United States, close to Canada, and fairly close to the United Kingdom, we have a massive migration problem. Out of every 7 nurses that we train, at least 4 migrate within 3 years of completing their program. And so we have a significant challenge as it related to that. However, we were able to execute, and the major lesson that we learned was, that partnership works. It is important that you have a partnership, and that partnership has to be with our international partners who have best practice and can share with us lessons around who already have done this, and you don't have to recreate the wheel. And that is what partnership creates. Also, we want to take this opportunity to thank the government of India, who provided a lot of the technology free of cost to us. And so we want to thank, but UNICEF was our biggest partner in this particular engagement. They were on board with us at the get-go. We had a country rep, María, I must make sure that I mention her name, who was as excited about this innovation as we were. And so we joined hands. And of course, we have to remember that a large portion, 60% of our primary care in Jamaica is delivered in the private setting, not in the public setting. So we had to join hands with the private sector in terms of rolling out the immunization platform. Next lesson, never waste a crisis. Never waste a crisis. We had to make sure that we optimized on some of the things that we could change because it was a crisis that you cannot change in ordinary times. Right now, we are going to be rolling out our regular immunization register, and some of the things that we could do during COVID emergency, the nurses are not taking us on. We have to go through the process with that thing. We also learned digitization is possible. It is possible, and that's a very, very, very good message. It is possible, especially within small island and developing states. And lastly, the message that we got was that change management is key. Change management key. You must have a change plan. You must have your resistance management strategies. You have to ensure that you engage and encounter all the stakeholders. Do your stakeholder analysis. Do your risk profiling. Ensure that you embed within your planning that change management intervention to ensure that you overcome. You have to have a philosophy on how we are going to implement. And our philosophy in Jamaica is 1 patient, 1 record. And so because we're on that philosophy, we don't necessarily have to start our process with the electronic platform first. You start from your policies, and I'm happy that that message has come out in terms of policies or legislation or regulations. It's very important that you start from there, that you set a framework as to what it is that you mean when you say digitization, especially in health. Within Jamaica, we are now, we have structured our Data Protection Act to look at those risks around data protection. And because just one instance of a data flaw can ruin the trust factor. And within change, trust is golden. And you must have trust. The people must believe that this system will benefit them and that there's some value in it. And I just want to say thank you to the team. I want to say thank you to the team in Jamaica for making a digital transformation happen within 10 weeks. An impossible task that we achieved together. Thank you very much.
Thank you very much, Dunstan. So now I'm happy to introduce the last panelist in order of intervention, Lee, Han, Bryan, Wong, Youth for Health Network. So Bryan, you represent in this panel the voice of young people, and we know how much is important the role of young people in remote and rural areas. And I would like also to stress that Youth for Health has also drafted the outcome statement of the conference that we will be presented in the final session today. So Bryan has been involved in many initiatives and research related to PHC, equity, governance, and digital health. Can you share with us your experience giving example of interventions and initiatives to address the access gaps? Over to you.
Great, thanks. So thanks again to the Youth for Health Network and to WHO Europe for inviting me to speak. So as mentioned, we have drafted the outcome statements, and I'll just preface my interventions with kind of three key implications that the outcome statements do have for young people, and this was reflected in our virtual roundtables and the consultations that we had with young people. So I think the first was around ensuring equitable and inclusive access to primary health care. I think it's really critical to understand that young people, particularly in rural and remote areas, often find themselves in a digital divide. We've got the appetite and aptitude for digital solutions, but might lack the access of literacy. There's also the important aspect of we've heard already about ensuring this human aspect of primary health care, and I think while digital innovations do present this transformative opportunity, technology should complement, not replace, the human aspect of care. One thing that we really saw through COVID was that young people really value genuine connections, and this cannot be forgotten. Digital platforms can facilitate communication, but it's really that human touch, that empathy aspect, and the understanding that make primary health care truly person-centered. The third was around health systems resiliency. So I think recent events have really taught us the importance of being prepared. Young people are the future, but we're also the present. And I think our resilience is really intertwined with health systems resilience. So I think it's crucial that as we evolve and adopt new technologies, that our primary healthcare systems are designed to withstand future health emergencies, but while ensuring consistent and equitable access to care for everyone, particularly those in rural and remote areas. So on some of the initiatives that I've been involved with, the first one, I see my co-chair here from the Lancet Financial Times Commission, Ilona, is around meaningful engagement in governance when it comes to digital health. So, we published our report 2 years ago, and we really highlighted the importance that digital health governance needs to really safeguard the futures of young people. It's not just about regulations, but about ensuring that digital solutions are equitable and prioritize the needs of young people. We looked at a concept called digital childhood profiles, which we see that young people growing up in digital worlds experience these extremes of digital connectivity. On one hand, both within and between countries, they're really diverse experiences depending on their levels of access, their socioeconomic status, and their geographic location. So some are digitally consumed and therefore vulnerable to harms online, while others are completely excluded and might remain totally disconnected. And that might cause them to miss out on some opportunities with respect to how technology can be used to support their development, well-being, and health. The second was around this concept of digital first health system. So I think young people really want to be playing a role in both the design and the governance of digital first health systems to really ensure that they're responsive to the diverse needs of our generation, and really that there's a balance between this what we call data solidarity, right? So this balance between the individual rights and the collective goods to make sure that these benefits are shared collectively. I'll then touch on some of my work with FIND, the Global Alliance for Diagnostics. So I just came back from Kigali, where we had the Africa Health Tech Summit, and Africa has a massively growing population of young people, and FIND is leading this connected diagnostics flagship in Africa. And it really demonstrates how digital tools, such as remote diagnostics, when they're really integrated with telemedicine and telehealth services, can really revolutionize healthcare delivery in remote areas. So we did some site visits. One of them was with the Society for Family Health in Rwanda, and María touched on this concept of health posts. This was a really good example of sustainable provision of basic health services. They were, completely off the grid. They had solar panels, they had Starlink, satellites, and it was a really great way for, the ministry to improve access to care in rural communities. There was also Zipline, which is autonomous drone delivery of medications, medical supplies, and samples. And it was a great example of how local innovation can really scale. There's community engagement because with all these drones flying around, they were able to engage their communities to collectively understand the benefits of these drones and how they can really drop and deploy medical supplies when they're needed in really remote areas. And the third was, we heard from Dunstan about moving from paper to digital. Some of our work in Guinea with respect to community health worker implementation of digital health with an organization called Clinico. So what they did was, in Guinea we've got 100 million people that lack primary health care. And what they did was they employed familiar digital tools like smartphones and apps, and Google Docs and things like that, but innovatively. So they really empowered local medical professionals to offer more efficient healthcare. And what they did was, rather than impose solutions, they collaborated with communities to train trusted locals to ensure that the interventions were sustainable and adaptable. So they moved from paper-based records to a digital health ID card that was accessible remotely. And they did this, through partnerships with Ministry of Health, with NGOs like Find, to really facilitate, integrative diagnostic testing within their digital health framework. And the final thing that I would say is through my work with Transform Health, where we're advocating for, increased investment and closing the funding gap. And we had a youth-led research for a report that really underscores the crucial role of involving young people when it comes to digital transformations. And in that report, we really urge both public and private sectors to invest in digital health solutions that are tailored for young people, while emphasizing the need for initiatives in financing, health literacy, training, program evaluations, and production of evidence. So hopefully from all this, you've understood that there's kind of 5 kind of key things that are needed, I think, when you talk about bridging the gap. First, meaningful youth engagement in governance. Second, capacity building. Third, cross-sectoral partnerships, as we heard. Fourth, interoperability with existing infrastructure and health systems. And 5 is meaningful and better coordinated investment. Thanks.
Thank you very much. Really inspiring and also very good to understand how to connect some dots that look very far away, but it's a very good example how different initiatives can be integrated in a common vision. And also about young people, I might say if primary care is about also solidarity and social justice, is also about solidarity between generations. So also maybe we can work also a bit more on intergenerational solidarity. Now, if you agree, I will keep the Q&A session because I think that we are running late, but I will keep 5 minutes of Q&A session and I leave the floor to John to manage the, let's say, discussion and Q&A.
Okay, thank you very much. Wow, Bryan, that was amazing. It all goes to show that actually it's this generation that actually has the future for rural health. And if we don't support, if we don't enthuse them, if we don't guide them when they need guidance, if we don't mentor them, then I worry about the future of rural health. So thank you, Bryan. That was particularly important. I'm going to go back to our panelists here. I mean, what actually we've already shown is the diversity of rural. One size does not fit all, María said. And in fact, the great Roger Strasser said, when you've seen one rural community, you've only seen one rural community. And it's diverse. And the other thing, and in fact, Andreas mentioned this, and this is another saying that goes around, if it works in urban, it won't work necessarily in rural. But if it works in rural, it'll always work in urban. So we are the test bed. So I'm going to ask my colleagues here for a very quick answer. If you had the ability to change the world, what would be the one thing making a difference in your rural communities? I'm going to start with Jamaica. Sorry, I put you on the spot.
Wow. So So I think the one thing that we'd want to change, to create, is education.
Okay.
It's education. I believe that if we create more understanding of digital technology and digital literacy, especially within rural, because the major challenge that we had in Jamaica is around trust.
Okay, so it's education, education, education of the communities, of the patients, of the workforce.
Yes.
Great. Bosnia.
Let's say support for the family living.
Okay.
Because we have the migration and we don't have families in the rural side. That's very important for health and welfare. So any kind of support for family living.
Fine, and I would agree with that. Interestingly, there was a paper from Catalonia saying that the reason that workers that have been trained in rural areas go back to urban areas because of family connections. So that's interesting. María.
My dream is internet connection for every family and transportation services, including helicopters for people that need it in emergency situations.
Yeah. Okay, that's great. And we know that there are interventions happening using simple technologies such as mobile phones, and I know that this is happening in Kenya at the moment. So that's really exciting, and I would agree. Andreas?
Well, if I want to mention one thing, I would say recruitment and retention issues, because that's very, very crucial. When it comes to recruitment and retention policies, but better ways of recruiting and retaining staff in rural areas. I think that would have great impact on rural healthcare.
Yeah, I think you and I spoke earlier on. I have this passion that, in fact, one of the problems that we have is the solid barriers between primary and secondary care. And the countries that have succeeded, like Australia, have blurred those boundaries so people can cross over. And I think that's really important. So, yes, I agree entirely. Bryan, I know you've talked about the future, but here we are, your opportunity now.
Yeah, well, on opportunities, I think I would say provide more opportunities for young people. I mean, let us lead for our own health futures. Thanks.
And I think what we'd like to know, Bryan, is, is we need to turn these opportunities in rural areas to exciting opportunities, to make them special, because people want to choose to go in rural, because rural is exciting. So we have a little bit of time left, so I'm leaving it open now to you all. Please, over there, sir. Yeah, I think you need to shout so we can all hear. Yeah.
My name is Dr. Bryan. I'm the WHO representative in Rwanda. One question, Jamaica, PS Dunstan. Very impressive initiative. But my question is on what you have learned. So you've learned a lot, I reckon, from this digitalization. But how are you going to build on it, or have you started building on it, to be able to institutionalize either the digitization of the rest of the immunization system or other aspects? What are you doing?
Okay, I'm keeping these very short. Dunstan, I'm sorry, we're putting you on the point again. Very quick answer.
Quick answer, yes, we have started to institutionalize. We are implementing an electronic immunization register that takes into consideration the life course of all of the immunization programs that we have, all of the antigens that we provide to the population from birth to death, I guess.
Okay, look, two very quick questions. I'm ever so sorry, we are short of time, but look, come and ask us afterwards, because we're all here. We're not going to go away. So quick question.
Okay. My name is Christian. I'm acting representative for the WHO office in Mali. I have no question, but it's a requirement. We listen a very interesting experience. But I don't know how we can get all the documentation, all the experience, particularly concerning the legal framework for digitalization. Because this is very important for us.
Okay.
And see how to implement in Afghanistan.
Yeah. I think rural is the big issue. And it's a shame that rural's got the smallest room while the other room is over there, really. And people haven't got that head in their heads around it, you know?
Another requirement is regarding the experience related to deployment of some procurement, like blood bag in the rural area, in the remote area by drone. I don't know if some of them have some experience about it.
Go and ask Bryan afterwards. Very quickly, you put your hand up.
There was the lady.
Okay.
No, there was the Montenegro, lady from Montenegro. Yeah.
Yeah. One last one. Go on, very quickly.
Very quickly, if I had the magic stick, doing what my colleague said, I would also go for integration. And as one of you said, that digital technologies are offering us an opportunity, but definitely it is a challenge. So we have to be very responsible with the digital technologies, because it might lead us also to inequality. Great session.
Okay.
Quickly, other two, the lady
Go.
and the...
Right, very quick.
Yes, so my question is on uptake of digital services, and if and perhaps in what ways participatory approaches help with that. Because we know that we have a lot of supply-side tools out there, but sometimes digital literacy in populations is not all the way there, and I didn't know if that has played a role in the design of any of the services or what you've done.
Yeah, I think that literacy is really essential here. And one more.
Well, yeah, the lady.
Literacy and family connections. Because the young people actually teach the old people to actually use these services. So literacy, but also these connections with the families.
Yeah, it's my children that teach me. So.
Yes.
So one more.
Hi, I'm Artemisa Hamilton.
Can you stand up and shout?
I'm Artemisa Hamilton from Bryan. Question from Bosnia. What are the task shifting that you have to do with your health force to be able to have all of those services available in rural communities?
The answer would be very wide, so I don't know do we have time to do that, but I'd rather stay with you just to explain you all the things that you can ask me. Yes, of course, please.
Thank you so much. Thank you.
Okay, thank you very much. Thank you very much also for this interactive, brief but very interactive session. Now we have asked to Rudi Eggers, that is Director of Integrated Health Services at headquarters, WHO headquarters, to give us the final reflections on the session. Rudi, please.
Actually, thank you, Matteo, and it's been an amazing story of all these countries. Maybe let's give them a hand. So just to start off with the word rural, you started with that comment, and what we've heard here is 5 different rural settings. Really imagine, what does rural mean? It means that Indonesian island, it means that Rwandan village that actually is quite dense. It means that alpine village in Switzerland. It means the Papuan forest dweller. So rural in itself is such a broad concept that we need to imagine this one-size-fits-all absolutely does not apply. So just as a starting point, in this area where we are actually feeling quite connected, I think this is one of the key malaises that we've heard over and over again, is that in this connectedness, we're actually quite disconnected. And it was something that you had reflected on in the youth concept. And just reflect back to the comments made by the health worker this morning, with all the technology, all the possibilities, what the feeling is a feeling of being overwhelmed in that context. And that, I think, is also reflective of your comments from the rural areas. Okay, let me just summarize 2 or 3 points. The first thing, PHC is about bringing care to the people and bringing people to care. So the concept that increasingly we're talking about is nearness, bringing together. And this is something that maybe is the common factor between our discussion on the rural health services, where we're trying to bring the health services to the people. Like in Sweden, you've got the community hospitals, etc. And the concept of digitalization, where you are somehow, either through the person's personal phone or through some digital health mechanism, again, bringing services much nearer. So that's maybe the other area of overlap. When I first started in this area, there was a lot of talk about people-centeredness of health services, and we've talked about that here as well. And frequently I've asked myself, well, what does that actually mean? What does actually mean people-centeredness? And I found the answer is we are the people. So let's ask ourselves the question, what do you want? So if your mother is brought to a hospital, what type of service are you wanting? If your child gets ill, what is the service that you are expecting as a person, not you as an official or minister, you as a person with a sick child? That's what people-centeredness means. So those are the two concepts I just want to highlight in terms of the primary healthcare concept that we're working with here. The concept of nearness, bringing into the rural, into the sparsely populated, the services and bringing the digital health to them. We heard yesterday, some of you might have been there in the Kenyan discussion, also a little bit more about the maybe pre-primary care, the care that is in the community just before they get to the primary care. So in Kenya, we've got the community promoters now, which form a sort of an interface between formal health services, that doctor, that rural doctor or that rural hospital, and the community, and engages in that manner. And that's maybe where something we can also build upon. In some countries, it's very well developed. In others, it's really a solution still to be found. And there was a lot of mention about the multisectoral and integrated teams. I think you mentioned it. Because it's no good coming to a facility and then be served with one service, or coming to a health worker and just getting vaccination. As good as that is, we do like vaccination, but it does need to cover all the areas. On digital solutions, we've heard a lot. It very clearly is the future. It really is a worthwhile solution that we cannot discount anymore. It cannot replace the human contact. I think that was mentioned a couple of times. It is one of those tools to bring nearer, to deliver health services. I think there were several sort of warning messages as well. The legal framework that we need to have behind it, but then also the digital governance that was mentioned. So how do we make sure that this digital health that we are providing is actually bounded in the correct way? And we need to find solutions there. Amazing story about Jamaica and a 10-week implementation. I don't think I've heard of anything that is implemented in 10 weeks like that. So quite an amazing story. That's the other part of it, of course. We can talk a lot about the digitalization. It's really making it work. And it's not only putting the tablet into the hand of people, but it's making the people feel comfortable with actually using that tablet, using that computer. And it might be easy for the youth generation. It might be more difficult for that health worker that actually has been working for 40 years and now has to be confronted by a screen. So it is both, digital health implies both the equipment and the ability to use it. At the end of the day, let me just close this discussion with, in all of this, in all models of care, how we deliver care, it really is the intentional planning that makes it work. So it will not happen by chance. Rural health, rural facilities, they don't happen by chance. You really have to plan it carefully from the beginning to end with intent of solving that problem. And that includes also the digital health component. Let me stop there. Thank you very much.
Thank you very much, Rudi, for your availability to summarize and also to keep food for thought for the future and going home and working on this. From my side is just to thank everybody, starting from the technician, because without people on the background, it's not possible to have all these sessions. Thank you to Laetitia that accepted to co-moderate this session. Thank you to the panelists, to the speakers, and of course, most important, thank you for all of you that you have joined. Thank you. Now there is a new plenary session in the big room, and please, the last applause to the panel. Thank you very much.